And just to confirm before we get started, everyone can see that opening slide there? All right, yep. Awesome. So thanks for the opportunity to present today. I'm Josh Gaither.
All right, I'm Amber Rice.
And we're going to talk to you about the Arizona Rural EMS Advanced Telemedicine demonstration project. So we're really excited to be here.
Perfect. So this project really came out of a need from some of our rural EMS agencies here in Arizona. So Southern Arizona, we have a sort of large regional area, a big metropolitan city area with some big EMS agencies, and then sort of surrounding the Tucson area, we have a lot of smaller rural EMS agencies, most of them based with our base hospital medical direction group. So the purpose of this project was really to develop an infrastructure. So put in place a system that would allow a rural EMS provider to be able to contact an emergency medicine physician and put them in communication real time with a two-way video communication system. So obviously there are some barriers to doing that in the rural setting. So that's what we really presented on last year, was sort of the barriers that we went through in setting up this project. And this year we're going to talk a little bit about the outcomes and sort of where we are now. So this project also allowed us to try to demonstrate that this could be a sustainable model for rural EMS care. By giving EMS medical direction at the time of patient care. So instead of having to go back and retrospectively look at patient care reports and try to provide feedback after the fact, it really allowed us to communicate in real time and share with the EMS providers our thought process in medical decision making and work with them to try to find really the best solution for that patient at the time. Our partners in this were mainly the Arizona Center for Rural Health. So out here, we did this project together. They have a lot of resources and a great outreach program. So we always love working with them. We also have partnered with General Devices to use their Ebridge platform, which is the software platform that allows us to do the communication. FirstNet from AT&T was the cell provider platform that allowed us to sort of improve the telecommunications by improving the cell service throughout the area. The Arizona Telemedicine program, and then HRSA, obviously. We partnered with two rural fire departments, Sonoyta, Elgin, and Rio Rico Fire. We're going to talk mainly about our project in Sonoyta today. And then obviously the Department of Health Services, one of our partners in many of our projects. So this is Southern Arizona, as I have mentioned. So you'll see Tucson, the metro area there, and a very large area of rural EMS and rural communities in Arizona that are serviced by much smaller departments. These were the two projects that we worked on. Like I mentioned, we're going to talk mainly about the management of patients with chest pain by our Sonoyta agency. And the goal here was to improve resource utilization. And they use this mainly on calls that patients had a chief complaint of chest pain. And then our physicians would look at the EKG and provide some expert services to them. The other project that we worked on alongside this was the Rio Rico Fire Department Telemedicine Treat and Refer program. So in this project, the goal was really to provide more urgent care services through telemedicine to patients that maybe didn't need to go to the emergency department.
All right, so let me tell you a little bit about Sonoyta. So Sonoyta, Elgin's kind of down in the eastern side of southeastern Arizona. It's kind of what I would call the middle Sonoran Desert. It's not really low, it's not deserty, but it's not really high either. It's kind of that grasslands, really beautiful country. It's where actually, if you ever have had wine from Arizona, it's our wine country of Southern Arizona. So really beautiful area. It's a very dispersed population. They have a city center, which is one stoplight, and the citizens that live there really do live in ranches spread across thousands of acres. So we worked with Sonoyta Elgin Fire District on one of our kind of initiatives. And really what we looked at them was, how can we innovate in the management of chest pain patients? And last year we talked a little bit about this, but really what we focused on is we wanted to teach the EMS crews, hey, when you get on scene with a chest pain patient, go ahead, do your assessment, everything you normally would, then give us, the doctors on call, a ring via this telemedicine platform. So any patient with chest pain, they would give us a call. We would pick up via our secure live video conferencing offered by Ebridge, which is simply an app on our cell phones. It was really easy to use. We all ended up with it just on our personal cell phones or a dedicated work phone, depending on the doc that was on the day. And really what we would have the crews do is walk through with us, what's your patient? What do they look like? They would turn the camera so that we could see the patient. And then we'd help them through the decision of, could this patient possibly go BLS, which prior to this project had not been allowed, right? The BLS crews can't interpret 12-lead EKGs. They can't determine if there's a STEMI or not. And really, with that physician present, we could take the leap to say, yeah, that's not a STEMI. If you're a BLS crew only on scene, yeah, that's probably okay. Why don't you go ahead and transfer that patient to town? It's a 50-minute drive via BLS and save that helicopter ride. If it's an ALS unit, we tended to have some more complicated calls with those ALS responses. I'll talk a little bit about that in a second. And then, of course, if it was a STEMI, we would recommend that a helicopter fly in to decrease that transport time and shorten the time from 911 call to cath lab activation and patient to the cath lab for revascularization. We then, of course, had a retrospective part of this. We wanted to know how this project worked. So on the backside, after everybody finished the call, we created a red cap survey simply for quality improvement to look at how well did that call go? Did the technology work as we expected it to? What was the video call quality? All that type of stuff. And really, at the end of the day, the goal of this project was we wanted to get the right patient to the right destination via the right transport modality. And when it was safe, that meant transporting patients with chest pain via a BLS unit. And that allowed the only ALS unit in the district to stay in service. And let me give you an example of perhaps why this is so important. Sonoyta only has one ALS provider on at a time. A couple weeks ago, we happened to be out at Sonoyta and they had 3 911 calls at the same time, right? So you have to decide which of those 911 calls is going to get your ALS paramedic and which are going to get the BLS paramedic. So imagine if your ALS provider is on a transport to the city and that transport's going to take between 4 and 5 hours. You're leaving your entire district, most commonly during the peak call times, without any ALS coverage. So this was really important to the fire chief and leadership for this fire district down there, was to improve ALS availability to their district when it comes to these types of calls. And then obviously there was a second goal, which was when it was safe to go by ground, saving the citizens of the community the cost of air transport. What was happening was that if a BLS provider was on scene with a chest pain patient and that BLS provider got a 12-lead but couldn't interpret it, and they didn't have another ALS provider there, they were forced to call an air medical resource to transport that patient in, even if they didn't find any abnormalities, simply because they weren't trained in the interpretation of those 12 leads. So cost savings was certainly a secondary goal. So how did this work? This is kind of what it looked like, just as a refresher. I know we shared these screens last time. What you see on the right is what the EMS provider would send to the physicians. So they would go, they would see the patient, they would obtain a 12 lead, and then their ZOL monitor would automatically upload into the system and allow them to send the 12 lead and the vital signs for the patient to the physician on call. Our phone rings, it's a really loud, obnoxious ring. We go ahead and hit the little camera, and then it pops up with the image on the left there, which shows the EMS provider and the physician who can do a face-to-face talk, look at the patient, and all that type of stuff. This really does, I'll give you the anecdotal experience, right? Having been the doctor on the other side, it's amazing how big of a difference this makes from the physician side. I took a call this last weekend, maybe last Thursday, Friday. It was a patient with chest pain, and the medic did a great job of describing it. And then as soon as I opened up the 12 lead, it was clear that the patient was an AFib with a heart rate of over 170 and some runs of VTAC, a very sick patient that without that 12 lead, I wouldn't have completely appreciated how sick the patient was. So rather than starting the helicopter right away for that patient, which is probably what they would have done in the past, we were able to talk through, let me look at the patient. Let's try some diltiazem because I know that's what they have in their drug box. And we're able to slow down that AFib with RVR to a manageable rate. Patient's chest pain went away, and we elected to ground transport that patient to town via an ALS resource rather than fly that patient to town. So that's just an example of how the system kind of works. So with that, I'll turn it back over to Amber to run through what we found.
Sure. So looking at this particular part of the study, so this is the chest pain calls that we received. So our research coordinator has gone through and read many patient care reports to pull some of this data, but we went back before the study started and looked at all the patient care reports with the chief complaint of chest pain. So if you look on the left is our baseline data. So this includes really the year before we started taking these Ebridge calls and doing this project. And then on the right-hand side is their post-implementation side where we have a number of calls. You'll see that the dates are slightly different. It's slightly more than a year in the post-implementation phase where we collected this data. But in the end, interestingly, a slightly lower number of chest pain calls as a percentage of total calls in the post-implementation phase. We still have some data cleanup to do on that side. So that could change those numbers slightly, but probably pretty close to that. If we look at the breakdown by gender before and after, so prior to the study, the baseline data revealed that about 62% of what were chest pain calls were male patients. And in the post-implementation phase, you'll see obviously fewer chest pain calls and a lower overall percentage of male, so a little bit closer to 50-50. When we look at chest pain, patients that have chest pain calls and look at the sort of the call volume and the transport statistics, so this is what Dr. Gaither was referring to in terms of how they're transported to the hospitals. And the leftmost columns are how many Ebridge calls we had. So of all the chest pain calls that we had in that post-implementation phase, about 63% got a phone call with a physician to talk through the decision-making process there, compared to obviously 0 in the pre-implementation phase. If we looked at those that went by BLS transport, so we had an overall increase in those that went by BLS and a decrease in those that went by ALS transport as a percentage of chest pain calls. Air medical transport, not a really significant difference there. These are relatively small numbers. And then the number of patient refusals went down slightly in that post-implementation phase. Often that's because a physician talks to the patient and says, you know, this really is a significant concern. We think you should go to the hospital. And many times the patient will defer to the physician and say, okay, I'll go to the hospital if it sounds that concerning to you. So we kind of expected maybe to have some fewer patient refusals just because sometimes we can be slightly more convincing. If we look at the total out of service time, so this was obviously an area of interest for Sonoida because of the fairly long transportation times. There is a fairly local hospital to them that is, you know, I can't remember how far Holy Cross is, like
it's like 45 minutes.
45 minutes versus driving all the way into Tucson, which would be a sort of several hour round trip for them to get all the way to Tucson if they needed to take them somewhere that actually had a cath lab. So if you look at the baseline data, we looked at the total out of service time. So from the time that they're dispatched and leave the station to the time that they're actually back in the station and back in service again to take another call. The baseline data showed that they were out of service on average for chest pain calls, a total of 122 minutes. So it's the average total out of service time. If you look at the post-implementation phase, it looks to be about a half hour shorter almost, like about 30 minutes shorter in the post-implementation phase. So that's a fairly significant decrease in the amount of time that one of their units is out of service for a chest pain call. So in summary, we were able to effectively implement the study, and we had really more than half of our chest pain patients that got a phone call with a telemedicine EMS physician. And so these are very small numbers, so we didn't expect to see significant changes in terms of statistical significance, but there were changes in the direction that we had hoped in terms of decreasing ALS transports, improving out of service times and things that really would make a difference to the service they're able to provide to their community members.
All right, so switching then from the real data driven portion of this to really more of the subjective component, which is what did the end users, whether it's the docs or the paramedics, EMTs, think about this program? On the physician side, obviously, we both took these calls, so a lot of anecdotal experience. I think across the board, our team, which you see in front of us, really did enjoy this experience. It was really fun to get to know these medics kind of because you see them on a regular basis. That seeing them helps you get to know them, and you really develop a much better relationship than we did have by operating with them over the radio only, which was quite unexpected. I think across the board, our doctors enjoyed the experience, and it was good for both sides. We did want to really focus on how the providers felt about this. So we actually conducted some focus groups to really explore what did our field providers think about this project, and is it something they would want to continue? We conducted several focus group meetings. Someone who was not connected to our primary project went down to both Rio Rico and Sonoyta and conducted these meetings independent of our group because we didn't want them to just say nice things because we were sitting there. So that individual identified several positives and negatives of the project from those two agencies. Here's the positives. The EMS personnel really did feel relieved of some of the strain regarding difficult transport decisions. And I think this one is illustrated in the case I had this past weekend. Some of these cases are really tough. They're tough for me as a doctor to handle. It's really tough for a paramedic working in a rural setting to manage when they may have not seen a patient with that specific problem, rapid AFib with runs of VTAC, in 2 or 3 years. So having someone to kind of weigh in, reassure them, yes, this is scary, but I think you're doing the right thing, they found very helpful, which was good to hear. They also said they had less pushback from patients on treatment and transport decisions. I think this is really reflected in that decrease in refusals that we saw in our objective data. And then they received enhanced and prompt support in comparison to conventional medical direction. This may be somewhat of a Hawthorne effect, right? We were all really excited about this program, so there's obviously some bias in that we were excited to pick up the phone. I'm sure they got a little bit more enthusiastic response than they did for a normal radio call. Important also to acknowledge the negatives of this. There were some instances where the EMS called and the doctor didn't pick it up, or they didn't pick it up within the 5-minute window that we had told them we would answer it. And this is very true, right? At 2 in the morning, if I don't wake up right away, sometimes I miss a call. So this is very true and a true limitation, which we're working to address in the sustainability phase. There are some connectivity issues. I'll add in my color perhaps. This is much less than they anticipated. Mm-hmm. When we started this project, they said, oh, it's not going to work at all. It's not going to work. In the end, there's only one small stretch of highway where they can't get a hold of us, and that's a much smaller problem than we anticipated.
Yeah, we thought we were going to have to buy satellite phones. They said, no way, we have to use sat phones. This will never get off the ground. And with the FirstNet service expanding into more rural areas, it really did help the coverage issues. So
yeah, and then last but not least, one of our agencies, Rio Rico, did use iPads, which had a decreased durability. In retrospect, the smaller iPhones with some really tough cases were much more functional than iPads, which are bigger and easier to break and also harder to repair. We did look into kind of quantifying their feedback. So this is a quantitative analysis of those focus group feedback. We really grouped their feedback into 5 different categories and then categorized it as positive, neutral, or negative. You can see here on the graph, the far left-hand side of the graph, effect on direct interactions with patients. Most people felt that that was a positive, that the technology had a positive impact on patient impact. Transport decisions, this is that BLS, ALS, or HIMSS, right? Across the board, we had positive feedback. They felt that it was a good tool to help with that decision making. Technology and connectivity, not surprising. That was their least favorite part of this. Kind of how I would look at this data is that we did have to do a lot of refreshers. This is, you all are familiar with this, right? The first time you open up a new device, a new app on your phone, you have to learn how to use it. If you don't use it for 2 or 3 months, it's like starting over every time. We had a lot of those experiences with this project. I think if we were to look at how to make this better, ironically, using it more frequently would decrease these barriers to connection and technology that we had through this project, because we only looked at that one chief complaint.
And I think the anxiety of calling a physician sort of in the middle of the night and knowing you're waking them up, I think that took some time to overcome as well. That was probably part of that connection piece. But.
Yeah, absolutely. And then the protocol, this was a new protocol for them. A lot of those negatives is actually reflected of the Rio Rico program, which we didn't touch on in this simply because we're not going to have time. We did mandate that they call via Ebridge for Rio Rico for every refusal. That made them quite unhappy. So that's why we got a lot of the negative feedback about the protocol. And then finally, communication with the hospital, they felt was generally improved. So let's transition a little bit to cost and sustainability, which is what we're focusing right now on this. The cost of this is fairly significant. The software infrastructure cost about $15,000 a year. The hardware component of it, which is the phones and iPads, cost about $40 per month per unit, right? It's simply the first net service. And then the physician hours, on-call pay, it ranges, right? It depends on who your doc is. It could be $0 to $300 a day, which is obviously not very sustainable. And then the EMS level, we have to think about lost revenue as a significant issue. So how are we addressing that? So agency cost, really looking at treat and refer, which is our Arizona Medicaid program, and ET3 as a way to generate revenue that will offset the cost of the device for the EMS agency. And really, this is pretty minor. So if you look at it at an EMS agency level, if the EMS agency can bill for one treat and refer ET3 encounter a month, it pays for the cost of the devices for a small rural agency with a small number of devices. On the hospital side, the hospitals actually have to pay for that $15,000 infrastructure. That's how Ebridge developed their system. The hospitals are very interested in this locally from an enhanced communications perspective. They really want that service, that connectivity. And then secondarily, it's also an opportunity for the hospitals to provide a service, that being telemedicine. Our local hospital is very interested in promoting their own telemedicine services and see this as a platform that would help them to disseminate those telemedical services to rural communities. And then physician costs and physician on-call time. This is probably the most difficult cost to cover. As many of you might be aware, there is no mechanism through which EMS physicians can charge patients for any part of the services we provide. So really what we've had to fall back on for this is taking this out of our EMS physician group and turning it over to physicians working in the emergency department so that an ER doc who's on shift can answer this call in the emergency department while on shift as part of their duties to reduce that cost. Looking a little bit at treat and refer and ET3, again, treat and refer is the Arizona Access Medicaid system that we use here. And then ET3, which you're all familiar with, is available through Medicare. The hospital sales pitch, as I kind of mentioned, is this $15,000 for what? Well, here's the what. You get enhanced communication, an opportunity to offer telemedical services, improved preparedness, right? We did look at this for COVID response, and a community partnership, really getting to know and serve your communities. And then finally, we talked about this already, the physician cost. There's no good solution And we've really reverted to turning this back over to the emergency department docs as the primary user. Just real quick to sum things up, unanticipated barriers. Our rural EMS agencies, we kind of assumed, quite honestly, that they had a very robust electronic medical record system. With both of our agencies, we found, unfortunately, that this was not really the case. They have one. It was just much more difficult to use than we had anticipated, which really kind of created a barrier on the data acquisition side. We also, of course, like any agency, have high performers and low performers, right? If I had to go back, the thing that made this work so well with some of our agencies was that we had a high level leader who was really engaged with this project and made it work. And then again, there's of course COVID, which is probably why we had less chest pain patients during this. So with that, we have 2 minutes. I'll turn it over for any questions, comments. Thank you guys for your attention.
Yeah, thank you very much. That was a great session, very informative on that. And I do have one question from the chat, and that was when you were talking about the Ebridge calls, and we had just prior to you guys joining before earlier in the afternoon had FirstNet on talking, and someone was wondering what the difference between an Ebridge call and a FirstNet call would be.
Yeah, good question. So Ebridge is the platform from General Devices. So it's the application on the phone that allows a sort of secure, HIPAA protected, you can record these calls, that kind of thing. So it's the actual app that allows, that's like the FaceTime that we used. The FirstNet is the actual cellular service. So it's the broadband network. So they provide obviously you guys heard earlier that different broadband network that's separate from the main broadband network that the vast majority of folks are on. So the broadband network being FirstNet, and then the actual application is the General Devices Ebridge program.
Perfect, thank you. And Jill, I hope that answered your question. I think it did. Next one was, how many chest pain telemed calls per year are you guys doing?
I gotta go back to the slide for that one. Sorry, it's gonna take me just a minute. So in the before, it was 70 a year, and in the after, it was 45 a year. Mm-hmm. So it averages to whatever that is, 4 or 5 a month.
Perfect. And we got 1 more minute if anyone has any other questions or comments. I'll just scroll into the chat to make sure I didn't miss anything. I don't see anything else in the chat, and we answered all the questions. So, and we're right at the hour. So, any last things before we go here?
No, thank you very much for having us.
Yeah, we appreciate the time.
Absolutely, and I appreciate you guys coming and sharing this knowledge with us at the conference. So thanks again for being here. Really appreciate it.
Yeah. Bye, guys.
Bye, guys.
Do our obligatory double hand wave when you leave. So, all right. Well, I can't believe we're already at the end of the conference. This was a fun 3 afternoons. I hope you all enjoyed it. Trevor put into the chat the link for the survey for the meeting. That's really important for us, just to let us know how we did this year, give us ideas for how we can make it better for next year, and different session ideas that you want the planning committee to take account for. So yeah, if you can please do that. That'll also, if you go back to Crowd Compass on the meeting app, it's the last session for today. That link is also there. And then once we get all the video recordings and the actual presentations uploaded to the NoSOR website, we'll also email you to notify you that those are available. That'll also have the survey link on that too. But we hope you take a couple minutes to fill that out. Let us know how we did. We always want to make this better every year. So with that being said, though, I do want to thank our sponsors for the conference, the RHI Hub, the REV Ambulance Group, FirstNet by AT&T, Blue Cirrus, the National Consortium of Telehealth Resource Centers, and the National Rural Health Research Center. We'll be having some articles coming out in the branch newsletter in the next few months, highlighting these our sponsors for the EMS conference. So if you're not a part of the branch, go to the NoSOR website and ask to get signed up for that, and we'll get you on there so that you can see those. I know there's a few people on the call that were part of the planning committee. I especially want to thank Joyce Hospodar and Terry Mullins, our co-chairs of the JC Rec. I see that Nicole Clemens still on here too. She was part of planning this as well, and Talia Chappell at F4HP. Thank you all for being part of that planning committee. I tried to look through to see if there was any more, but those were the ones that stood out. So I apologize if I missed you. But from NOSOR and NSEMSO and the Joint Committee on Rural Emergency Care, thank you for joining us for our 7th annual and 2nd annual virtual conference. So again, fill out the survey, let us know how we did. Enjoy the rest of your evening and afternoon. I know it's sunny and 70 degrees here, and that only lasts about a day in the Midwest. So I'm gonna go enjoy that, and I hope you all do too. So again, thanks for being here. Thanks to Trevor with NOSOR in the background that was helping people get onto the app, and Beth Culp, she was running a green room the entire time with our speakers. And obviously Chris Salyers, Dr. Salyers was my backup when I kept getting hung up on today. So again, thank you everybody. I really appreciate it, and have a great rest of your weekend. Bye-bye.